Morning, ladies and gentlemen. Welcome to Vellore. Welcome to Autism 360. We're delighted to have with us an esteemed gathering of distinguished guests, experts, and learners, all united by a shared interest in advancing knowledge and care in the field of autism. It is a privilege to introduce Dr. Shoba Srinath, former head and senior professor of Child and Adolescent Psychiatry at NIMHANS, Bengaluru. A pioneer of child and adolescent mental health services in India, she has made enduring contributions to autism research, clinical care, and specialist training by establishing DM Child and Adolescent Psychiatry along with her esteemed colleagues Dr. Seshadri and Dr. Girmaji. CMC Vellore is honored to welcome her for the keynote address.
It's such a pleasure to be here this morning. I'm honored to be asked to speak today, the keynote address. All my colleagues who work with neurodevelopmental disorder, am I audible at the back? And we know that in autism, a lot of work is done by allied professionals. And there are not enough allied professionals. And those who work very hard. So dedicated to all people who work in this area. There have no conflicts of interest. So as practicing clinicians, all of us are trained in certain ways, taking excellent histories, being good listeners, observing, being a diagnostician, being aware of literature. And in the topic that we are talking about, we must understand everything through a neurodevelopmental lens. Actually, it's not only for the topics that we are talking today. Across child psychiatry, you're supposed to look through a neurodevelopmental lens. And if you go a little further, you'll understand that even in adult psychiatry, you better look through the neurodevelopmental lens, because everything starting with schizophrenia has a developmental issue. One has to be trained to be comfortable with practicing collaborative care. As MBBS students, at least in our time, our teachers and many of them gave us the feeling, and we had that feeling, that we were omnipresent, omniscient. All that we said as doctors, well, that's it, the ultimate. And working in a team was not modeled for us. We didn't have models of working in a team. But you will now see that working in silos, even in research, doesn't work. Even in research, it is multidisciplinary. You go for funding and you say, I'm alone doing it, you're unlikely to be funded. You say, my lab has a multidisciplinary group, you're likely to be funded. So collaborative care is something that one must know, must be modeled, and it's not easy. That apart, we also find that you have to have an understanding of all these affairs. And you will see, you will see that an understanding of family systems, trauma-informed, rights-based, lived experience is a big issue now, at least in NDDs and in autism in particular. In fact, when you write a project, you now have to take a person with a lived experience when you're writing that project, because you need to know what the person with autism, what are his views, and what is the point that he would like to be researched. Does he agree with the way you're doing things? And is it okay? The rights-based approach and the lived experience are big issues currently in 2026. You can't get away from the education system. You might be a doctor, you might be sitting in a hospital, but you better know how you will individualize your counseling to that particular family, with that particular child, to that particular school. And as we have gathered today, it is across the lifespan. We are going to listen to autism across the lifespan. So one of the things that I have always held, and everybody does hold, is that neurodevelopmental disorders is a big group. And the big group consists of IDD, communication disorders, autism spectrum, ADHD, SLD, motor disorders. In motor disorders, you have developmental coordination disorder. DCD, largely occupational therapists and physiotherapists spend more time understanding that. Medical professionals, clinical psychologists, social workers have not much of an idea of DCD. But the clumsiness of young people, the inability to play games, not taking part on the playground, are largely because many of these children have developmental coordination disorder. And that is not something that is easily understood. So this constitutes the group of neurodevelopmental disorders. Anybody would like to say which other disorder they would like to put into NDD, or which is the other disorder now being considered as part of NDD? Anybody? Any? Tic disorder is. Anybody else? Enuresis. Enuresis, that is primary enuresis, is being considered as a developmental disorder because after all, you see, it has to mature. The system has to mature, and we have enuresis in adults as well, primary. But nobody talks about it. You can't do a survey and say, how many of you are enuretic? Nobody will say, yes, I am. So you never know the actual number of people who are enuretic. In fact, it was found that in some army recruitment, when they looked at enuresis, they found adult enuresis to be 1%. Because in the army recruitment, these things will come out. And it was found across. So people believe that enuresis also is an NDD. Okay. Now, when I talk about ASD, I will start with NDD as a group and say that ASD has a lot of features of this common NDD group. So it's one big lump, out of which we have ASD. And that whole group of NDD looks after this. All these 4 points are there for all of the NDD. All of us agree that fostering of optimum development we want for any of the IDD, SLD, ADHD, ASD, for everybody we want optimizing of the development. I find that the neurophysiological basis of neuronal plasticity and these 3 points, I find them very, very useful when I'm counseling families. If you can get your families to understand this, not with jargon, but with your lay language, you would have motivated them to care for NDD, their child's NDD, on a long term. Take, for example, neurophysiological basis of neuronal plasticity. It is a concept very difficult for families to understand. And if families have not understood this, after n number of sessions, they will ask you, so when will you give the medicine? When will the tablets, when will you start the tablets? Which means that they haven't really understood what you've been trying to say. And when they go home, the first thing that a grandfather or uncle or aunt will ask, enna kodutanga marundu injection illa enna sonanga exercise pannanuma. So it is something that is so hard for them to comprehend when they come to a hospital. So unless there is a narrative for them to understand and they have understood why this has to be done, they won't carry the message through. So if a family gets to know that what they do in the form of training actually makes a change in the brain, it's such an empowering thought that I can actually make some changes in my child's brain by doing something that they have told me to. And in order to do that, they will have to comprehend the idea of neuroplasticity. And you can do any number of examples at their level. And one of the common examples that I give is most of them would have known fracture or whatever, whether it is actually a plaster or a puttur kattu, that hand will be immobilized for some time. And as a consequence of the immobilization, they know that they will lose muscle mass. They will know that when the plaster is removed, that hand is weaker than the other hand. Now, why did that get weak? What happened? Whereas the other arm, a lot of work had to be done because this was dysfunctional. This arm became stronger. So, what made this? So, the idea that if you don't use it, you lose it is something that if they get it, they will understand that the more I do work with my child, the more connections will be formed. The bigger will be the connection. The other examples that I tend to give is there's a well at the end of that place. It's full of water. This is a grassy place. The villagers go to that well for water. They keep walking up and down. And what happens, therefore? A path is formed. The large number of people walk, a larger path is formed. The well dries up. Nobody walks on that path. The grass grows again. So if you do work with your child and connections in the brain occur, the more they occur, the stronger they are. And therefore, you have a child who has a strong connection, having been stimulated or having been done something. The idea that they can do this, and one example that I often ask them to do is for drooling. All of you who have worked will understand that when there is drooling and you give exercise for the bucco-orolingual motor system, in a very short time, drooling stops. And who did that? They did it because you showed them that in a few weeks, months' time, drooling stopped. Drooling was such a nuisance for them. So the idea that they actually were competent enough to do something like this, and therefore, why not? Why not all the other training things that you're telling? So I think when you counsel, if you make them understand experiential deprivation and effects of stimulation. And this is also a very powerful way to make people understand about NDDs. If a child is speech delayed and the child can't express, and we all use speech and language to manipulate our environment. We get things done by the way we say things. If a child can't speak and the child is frustrated and troubled, what is likely to happen? The child has to still manipulate the environment. So the child will learn to manipulate the environment by crying, screaming, shouting, and having a temper tantrum. And when that happens, the environment is manipulated. The mother gives, the father comes, takes him out on the scooter. Now the child has understood that in order to communicate with the world, I have only this to do. This behavior problem is a secondary handicap. So a child had spasticity to start with. Nobody did anything for spasticity. The child developed contractures. That is secondary handicap. And so you may not be responsible for the primary handicap, but you definitely are responsible for the secondary handicap because you didn't pay attention to it. So the idea that parents get that if I don't intervene early, I'm going to have double trouble, especially behavior problems. And once they understand that and they see it happening, then they are motivated to do something about it. So the idea is we all have agreed that for NDDs, we do not have enough doctors, we do not have enough allied professionals. We have to have the family. If you have to have the family, then they have to be a co-therapist almost, co-workers with us. In order to be co-workers, they have to be empowered with knowledge. And knowledge must be at their level. And therefore, it is necessary for them to understand this because all through their life, they'll be doing this. So I want to generally talk about features of developmental disorders as a whole and ASD in particular. So all developmental disorders have these three issues. First two is well understood. It's usually on a continuum of mild, moderate, and severe. Every developmental disorder, you say, is on a continuum of mild, moderate, and severe. And our aim also is that if a child falls here and I do intervention, I can push my child towards the mild side. If my child has only a mild issue, I can push my child towards normal by the amount of work that I do with the child. And so this spectrum understanding is something that families must understand. The second thing is developmental disorders tend to overlap. You will hear more about it later in the day. John will do more about this. But I would like to just say that developmental disorders overlapping is the co-occurrence of these conditions are very significant. You will get various combinations and permutations of these. Therefore, I believe there is nothing like pure autism. So if I have a say in the matter, I will always say autism and other developmental disorders. And I remember Ashok and I having this discussion. So he said, I want to do something in autism. And I said, it is autism and other developmental disorders. So wherever you say autism, other developmental disorders will come along. So it cannot be just pure autism. The issue also is this diagnostic overlap is to be considered longitudinally also. You have a child whose current diagnosis is the ASD. 5 years, 6 years, child starts to go to school because child is normal intelligence. 6 years, child not doing well in school. SLD is starting to show up. So at 6 years, the child gets 7 years, 8 years, child is getting a diagnosis of SLD. It was not there earlier. Means it was there earlier. It didn't evidence itself. It didn't show up. So in follow-up, you might find that they get co-occurring diagnosis. So I want to say just this poem, because in nature, nothing is compartmentalized. Even in our Gray's Anatomy, we had the diagram of the homunculus. Everything was clear, where the lips are, where the hands are, where the thumb is, everything is clear. But that's just diagrammatic representation. All stuffs are like this. All connections are like this. So night becomes day and day becomes night in gradual shades of black and white. We humans wish that we could stop the time of light and call something black or white. Learn from the day and learn from the night that there is no true black or white. Actually, a diagnostic system is done for convenience, done for research. It is actually in practice, if you go and ask anybody about DSM and ICD, they say, oh, we always put mixed category because there's a mix of everything. But if I'm doing research, I will take a pure one because I have a question. When I communicate with somebody, I will write everything clearly because that's for communication. But actually, it is a mixture, and therefore it always autism plus or autisms. It is never autism alone. So if somebody says only autism, you will have to check. There is something called premature closure of diagnosis. And young people, when they get one diagnosis enough, over, diagnosis made. You have to check a little more. Depression and anxiety are not far behind. Child has got ADHD, also has depression. But depression doesn't get a chance to come in because we got ADHD and we decided that was a diagnosis. Okay. So they tend to overlap, likely to have multiple causes. I'm not going to talk about, we have Dr. Maya Thomas talking about genetic causes. I will spend some time there. All developmental disorders improve over the lifespan with training over time. There's no complete cure, but early detection and early intervention greatly improves the outcome. You would have seen literature where somebody says, autism diagnosed, 10 years later, no autism. Autism cured. SLD cured. But actually, with training, they will improve. But you dig lower in the surface, there are still developmental issues. The developmental issues remain, but the person has learned, trained, coped, and knows how to handle things. And this developmental issue no longer is a disability, no longer causes significant distress, but it's not 100% gone. But remember what we said about the spectrum. If a child is on the mild, then pushing the child more towards normalcy is a possibility. So training will improve, and there is no complete cure. Yeah. Children have strengths, preferences, sensory issues, and they impact multiple domains of a person's life. Sensory issues in autism, most people consider them as actually one of the primary features. But in DSM and ICD, they are not primary features in that sense. The hypo and hypersensitivity, rigidity, RRBs, all of them have been clubbed together. So the strengths and preferences, I find in child psychiatry, we don't spend enough time with our children finding what they like, what they are good at, what makes them tick, what gives them great pleasure. I think looking at a child as a diagnosis with which they come is very disempowering for the child. So if you take the strengths approach, then you will see that a child, whatever may be the reason, a developmental disorder or come with depression or anxiety or whatever, the child is more than the sum of the symptoms that they have. And so talking about that is actually very good for the child. So I often make it a point to ask the parent what the child likes beforehand. And if it is a sport or if it is something like that, I will bring that into the conversation. And you can see how that child's face blooms because they will tell you something that you don't know. Here you're in a position of strength. But there, if I'm talking about kabaddi and the child I know plays kabaddi, I have no idea of kabaddi. But if I ask him, he will launch forth into kabaddi. And immediately he feels that he is more than his illness for which he came. And coming to a hospital, most children find it very, very troublesome. And no parent will bring a child to a psychiatric center just like that. They would have spoken about it at home. They would have threatened him at home. Their teachers would have grumbled. By the time he comes to us, he's primed that he's one terrible creature. And so if he meets somebody here who actually thinks he's not just that, but he's something else, you've immediately got an exceedingly good rapport with the child. So it is necessary that even children with ASD have likes and preferences, and it's good for you to ask. The issue I want to point out is we want to keep a child, any child, and here we are talking about NDDs, active, useful, happy. I'm saying mildly challenged to higher levels of performance. I had a friend who came from Australia who told me, "Ma'am, my child is neurodivergent, has little unusual issues. I think on the spectrum also. But I have not told the school that the child is diagnosable because if I tell the school, they are so tolerant and so accommodating that they won't expect anything from that boy. They will leave him off. If he wants to go and sit there, they'll allow him to sit. But I want him to be mildly challenged because I know he can do, he's capable, and he can go up higher in terms of his ability to perform." But here comes the crunch. If you talk, and now neurodivergence, rights of autistic individuals is like an activistic trend. It is like an activism. And this is because a lot of these young people have grown up, they are articulate, they are bright, they speak, and they talk about what a terrible time they had in school, how people bullied them, how people forced them to do things that they could not do. So we know from their lived experience that it was a very tough time that they went through. So I always tend to err on the side of the child. So we have parents who have got children who are not intellectually disabled. They're going to school. And I feel the child has got mild LD and the child is not doing Hindi, Kannada very well. I will ask the family, why don't you give the child a chance to let go of these subjects? And the family will say, no, madam, later on in life, he will need both these subjects. Let him work hard now. It does not matter. But I know how many of you would have liked to have lesser subjects in school? I would have liked to have. Yeah, I would have liked. And here we have a child who has issues. Why can't we make his life easier? And there is an opportunity to do so. So to err on the side of the child so that he gets a little extra time because we know that life is going to be difficult for this child because he's not norm, he's not typical, and the world is made for typical people. And so our child has to struggle. So we make his life a little easier. Parent will say, you're making him lazy. So this line is very fine. And I want people here who deal with families to try to assess that the family might be pushing, but the child might be resisting. And that only you can tell them that take it easy. Your child is very stressed because your schedule is very big. You're pushing the child. How do we motivate ourselves? Same thing works for these children. So you'll have to find out what are the high points of this child's life. Child is autistic, has a lot of therapy to go to. Child loves swimming, but at that swimming time is OT time. So what will the family do? Take off the swimming. The high point of that child's life is swimming. So I'm saying that when you all discuss scheduling, you'll have to work with the family such that the child's high points are not sacrificed for the purpose of doing something that he's not good at. Okay. So that's what I meant when I said conflict. The teacher and the parent and the treating team might have a conflict on what is the goal. Leisure time, pre-work, and vocational activities must start early. People, you will find when children go to special schools or they go to inclusive schools, they won't talk about what's going to happen after class 10 or after. They will wait until class 10 comes. Family is troubled, what to do? And there is no place to send this child. So a lot of work must be done right from the beginning. And only people who are managing like you all will have to remind the parents, what have you thought? Your child is already 10 years. He is ASD. He is currently in a school. The school will keep only up till 16 or 17. What happens next? So there is CareAd, which is a big group working in St. John's. They are looking at it across the lifespan. And so they will talk about planning right from the beginning. So you need to have that factored in when you're working with families. Parents and carers have a tough time understanding this concept of comorbidity and spectrum and need it to be explained many times because each time they come, they would have forgotten. The reason this also happens is that doctors and therapists who see them also give them different opinions depending upon their training and orientation. So we have had people who will say, I will do training for your child 1 hour a week, 3 times a week. Mother, father, please sit outside. 1 hour a week, not enough. So clearly, the family must be told if they are going for therapy, what is your home program? Wherever they go, they must have a home program, whether it's OT, whether it's SLP, whether it's PT, whether it is special education. Family must know what to do with this child at home. How do they incorporate that into the daily schedule? So that can make families very confused. It's also difficult for families to understand that trait exists across populations. That's not for me, is it? 950, yeah. So if I take social communication and I plot a graph of all of you here in social communication, what do you think it will come like? All your social communication. It will fall on a Gaussian curve distribution. There will be some who are very shy and social communication not so great. There will be other lot who are gregarious, who are all over the place. And there will be the middle lot who are okay. And this happens for all these so-called ideas of the 3 major features of autism. It happens for social communication. It happens. How many of you are hypo or hypersensitive? Yeah, actually, I expect everybody's hands to go up because we are hyper or hyposensitive for something or other. So in our ASD children, they all club together. And because they club together, it becomes a syndrome. How many of us are very rigid in certain things that we do? But in these kind of children, it all comes together like this. It's hard for parents to understand that these traits are actually in general population. They also have to understand non-speaking children should never be presumed intellectually incapable. This is also true for children with CP. Just because they have CP and they are wheelchair bound, one believes that they are not intelligent. That's just our idea. So there are many nonverbal children in ASD who can understand, who can write, who can read. They just can't get across verbally. And this is what a lot of our neurodiverse population talk about, that impairment depends heavily on environmental fit and support. That if they are adequately supported by the environment, then a lot of their so-called disabilities will not be disabled. Now, these children are at greater risk for medical and psychiatric problems. Children with ASD, largely children with ASD and IDD. The SLD children, the ADHD children, not so much because they will be more verbal. And I find, and you will find, families having a lot of trouble with dentists. So I feel that people who work you all must have a list of pediatricians, dentists, general physicians, family physicians who know how to work with children with NDDs, with IDD. The reason being that having a DD gives a halo effect. So the child has some issue and they say IDD, no, must be because of that. Everything is explained as must be because of that, because these children can't communicate and you can't make sense out of what's happening to them. Okay. So certain disorders of the nervous system, like epilepsy, occur more frequently. We know that seizures occur more frequently than general population in children with ASD. There are two peaks for seizures to occur. It might be at a younger age, it might be in adolescence. And a lot of times you might actually have to tell parents without scaring them that certain kinds of behaviors that they come to tell you may actually be seizures and that you may not know. And that's the reason why children and adults with developmental disorders must have a medical evaluation at least yearly. So people who come to you, even for a casual follow-up, you must ask, who's your doctor? When was the last time you went for a dental visit? Do you have anybody you go to? It has been known, and this is the article, which says that the mortality risk for youth with neurodevelopmental conditions are higher. And suicidality in ASD is higher, especially in those who are verbal and who are articulate and who continue to have ASD features. So we are talking about medical needs and psychiatric needs which are not well met. Another thing that is not understood very well is neurodevelopment and emotion and emotional development. They go hand in hand, neurodevelopment and emotional development. For example, this is a nice developingchild.harvard.education is a nice site. So this business of children, like in tennis, serve and return, the child looks at something, a sensitive mother looks at the same thing, they share the focus, they go to and fro about that little dog which is outside, both of them are looking, they name it, and then the interaction goes on. This serve and return is a great learning experience. Attachment, bonding, and learning all occurs in this early years. And emotional development has to be understood along with early adversity and neurodevelopment. We all know that children with NDD, ADHD, SLD, ASD, IDD are at greater risk for being traumatized and neglected. All kinds of abuse, physical, emotional, sexual, whatever, they are at high risk because these children have these additional problems. And we know that when there is toxic stress and stress in the body, then the brain doesn't develop because the brain is busy fighting and flying from that place or freezing. So when the brain is involved in these activities, where's the time to learn? So these children's development doesn't work. So the implications for later anxiety, ADHD, and depression in a child who has had trauma is something that you must know beforehand, because you have to be trauma informed. I don't know how many of you have read this book. This book is big, can be boring, and but in places you can read it over time. And this gentleman has some YouTube stuff, good to listen to, talks about trauma, and does a lot of work in that area. So in our children that we see, we must ask for adverse childhood experiences and must ask for attachment behaviors, even in children with NDD, because it complicates the course of these children. If the child is neglected, doesn't have enough people to look after, or the child is abused, or the child is bullied, all this makes it worse for our child. Okay. So emotional competence actually acts as a marker for neurodevelopmental health. Delays or dysregulation often signal neurodevelopmental concerns. And naturally, they have a bidirectional influence, because that also has to develop along with whatever other development you have. So besides making a diagnosis of ASD, the workup should have all these things. And I'm sure all of you are aware about this multi-setting information. You will have a child who's ASD, who's working very well with a special educator. And the special educator and the mother's always surprised at how much this child works with that special educator, but doesn't work with the OT or PT. Why is that the case? I know of that only because I got multiple informants to tell me about that child. In child psychiatry, you must have history from everybody who deals with the child, because then you'll get an idea whether there's any differential way the child is being handled, or there are ways, something that this person is doing that makes this child feel very comfortable. So you can learn from that. Sensory profile evaluation, comorbidity screening, you'll get more about it later in the day. And this works not just for ASD, but this is for all NDDs. Now, regarding interventions, intervention is like a whole day workshop by itself. So definitely, I'm not going to be talking about that in great detail here. Applied behavior analysis, as it was practiced at one time, fell into disrepute because it was thought to be very punitive. It was thought to be very mechanistic, and discrete trial interventions were found to be too painful. But now ABA as a program has changed. They have included a lot of other things. They have taken in a lot of other formats. And so ABA is a very well-researched training, but people believe that it's slightly artificial, though the therapists who are accredited will tell you that things have changed. But I want you to know that the NDBI, which is much more popular, uses behavioral principles of reinforcement, but are specifically designed to be used in natural and social interactions, largely child-led, and they use natural reinforcers. They may be parent or caregiver given or therapist mediated. Lot of interventions are actually NDBI. But behavioral principles are not just ubiquitous. Don't all of us use behavioral principles in our daily life, with our bosses, with our children, with our spouses? Rewarded behavior increases and unrewarded behavior extinguishes. Yes, sir. We do it repeatedly. So behavioral principles are used ubiquitously everywhere. But ABA as a therapeutic medium is still used and has been found to be very useful. Many families use a bit of that and a large bit of NDBI. Speech language therapists, which includes social communication interventions and augmented alternative communication. Occupational therapy. I understand Vellore has a big contingent of occupational therapy and are into all units, adult, child, and I understand you have a big college and even a specialization course. They are in short supply world over. So the use of occupational therapists is absolutely necessary, especially for many of the activities that our children need to do. These are some examples of structured programs at different levels of evidence. Even the other one, even these have got different levels of evidence. Not all of them are completely evidence-based in that sense of the highest order. So these are some of the natural interventions at different levels of evidence. The ComDeal program is a good one. They are assessments. Then there is the parent-mediated or the PASS Plus, which Jonathan Green and Gauri Diwan and the lot have done in India. Then there are the little steps, and this is a caregiver-mediated for infants at elevated familial risk, where a child has autism, the sibling is at elevated risk, therefore, and what is the intervention that you do for that child? And then you have inpatient programs like that done in CMC, Vellore, and in NIMHANS. So CareAid has a program. So you will find that there are structured programs, but they are all at different levels of evidence, and parents use many of these. Pharmacotherapy. All of us are aware that pharmacotherapy has a role. There is just no doubt that it is used in these to good avail. When there is aggression, self-mutilation, stereotypes, you must be very careful, because stimming and stereotypes are phenomena that ASD people use to calm themselves. And when you find that a child is using that, you will have to do an ABC charting. What are the antecedents before the child starts doing stimulation or stimming or stereotypes? What actually is the behavior they do, and what are the consequences? And after doing this study, if you find it is actually done as a method of calming himself, then you don't want to stop that. In fact, we ask parents to give them time. You actually say, this is your stimming time. Go, settle down, do what you want. Because all of us have downtime. We all close the door and listen to music or do something that we want, because that calms us. So this child has whatever. So you use medication only when the stereotypes you've done your ABC and you find that the child is doing this beyond what you think is needed for the child, or that the child's whole day is spent in doing this, then you might intervene. Medication helps the rehabilitation process, and it has limited role, or I might say no role, in treating the core deficits of autism. Everybody is looking for a medicine that will treat the core deficits. And there have been medications which have been touted to be so, but they have not worked out well. But the use of medication in rehabilitation process is something that parents find it difficult to understand, especially parents who don't like medication. And you might have to actually tell parents that they may need the medication, otherwise the child might be put out of school or removed from the school. So just to get the process going for a short time, you may have to use medication. So there is one, this I find useful. This Autism Speaks has a resources for autism treatment. And that is quite a good thing on a medication guide. It's good for parents also. And we know that risperidone and aripiprazole are used for aggression and irritability. Small doses. There must be trial discontinuations. Medication cannot be a standalone treatment. That is absolutely clear. They must have other forms of treatment. You cannot give medication as a standalone treatment. This is a point to bear. Avoid use of medication to compensate for ineffective, inadequate psychosocial or educational interventions, and parenting and taking care deficits. A clinician must know when not to over-medicalize normal neurodiversity and when not to miss significant disability. Take, for example, a child who comes with, like I said, stimming. And you have understood that that child stims because of anxiety. That child stims because the child is overwhelmed. You cannot medicalize that and say that needs something to be removed. On the other hand, you have a child who hasn't been toilet trained. The child is coming to you for epilepsy and ASD, but not toilet trained. We have not asked about it. The mother at age 10 is still washing his backside. The child can't go to school because he has to be trained, otherwise, the school won't take him. And here, this has become such a big disability and such a big burden for the mother. And the child has been coming to a hospital, but we have missed asking what's happening to that child. So here, this is something that doctors have to pay attention, not just doctors, all health professionals who work with children. I'm spending a little time on this. How many of you here have seen your children on complementary and alternative medicine? Put your hands up. Yes, a whole lot of them. Do you think they will tell doctors by and large? They won't tell doctors that they are on alternative and complementary medicines. So, but this is ubiquitous actually. They are used to promote wellness. Basically, they are trying to see whether they will do resolution of core symptoms of autism. That's what they're looking for. The types of CAM treatment, natural products, mind-body practices, other biomedical treatments, at the moment, the big money changer is stem cell claims. Big claims of stem cells therapy. So, a doctor and health professionals working in this area must be informed about CAM because parents are confused and many times they don't know where to turn to. They don't know whose advice to take. And willy-nilly, you'll be forced to give an opinion on this. And therefore, you better be prepared and learn about it. Now, we know who uses complementary medicine, those with chronic illness, all these kind of disorders. Neurodevelopmental disorders, the numbers are high. 24 to 75% of people with NDD use CAM treatments. Okay. The most common treatment that ASD families use, natural products, mind-body practices, special diets. So this is a website that of FDA, and this gave the list of all the dangerous products and therapies which are claiming to treat autism. But you know what is happening in the United States at the moment with Kennedy being the health person who is anti-vaccine. This apparently, the FDA removed the whole page warning of dangers of unproved autism treatments. This actually was talking about claims about vaccine being causing it, alternative health businesses, all these were put down as fake. That site was removed and they said that they are redoing that site. So you can see that for example, in the United States, a family will be very concerned whether such and such a treatment works or not. Should I give it or not? So doctors and health professionals need to be aware of what works and what doesn't work. And so you've got to read about what this might do. So I usually will ask them, once I know it's experimental, I will look for the safety. I will look for what research. I look for the cost. I'll find out who practices, what experience they have. I will ask to meet people who have undertaken that treatment. Because oftentimes the advertisement is put by the person who is actually doing it. And they will give recommendations of people who said how useful it was. So if a family comes and asks me, I'll say, what is it? And I'll say, who told you? Where did you see? Have you met any other parent? Go meet a parent who actually used this. And I will ask them what it costs. Find out that they will sell a parcel of their land or a cow or a buffalo to order to go for the treatment and impoverish themselves in the process. Only you, because they come to you as a person trusted, are in a position to talk about should they or should they not. And most often, if they trust you, they won't go in for such a treatment. Whatever it is, I would say, for example, if I find that they are going to use casein-free and gluten-free diet, I will then ask them to construct an experiment for their child where n is equal to 1. So their child has a problem, they say, crying too much, having loose stools, or whatever is the target symptoms. So you chart it for 2 weeks. Chart whatever problems you have. You want to start a new treatment. Then you start your casein and gluten-free for 3 months. And you can't start casein and gluten-free for the child and you eat all the milk and the wheat you get in the house. Impossible. Families go into crisis. The whole family has to be casein and gluten-free if they want to make their child casein and gluten-free. Okay, so you have that experiment. Chat whatever you wanted, temper tantrums, loose motions, whatever. Then 3 months later, stop the treatment and give your routine food. Again, look for whatever you're looking for. If it works for your child, it works for your child. For your child, maybe it's allergic, maybe it does not work, maybe hyperactivity is more when he eats sugar. Okay, you have worked it out for your child. But you have worked it out in a manner where you conducted an experiment and you proved to yourself. Okay, your child henceforth you need not give. But don't just do it and pretend as if it's working. Whatever you do, you cannot forget to do other intensive training for the child. Stem cell, we had a child who went in for stem cell therapy for 3 months, did everything, came back, forgot everything that they had done earlier and trained, finished. They had to start all, not only had they become impoverished as a consequence of the cost, they had now to start from scratch, including toilet training that the child had lost. So it is only the trusted health professional who can actually counsel the family because they trust you and they know you. These are innovations of care. For care, many people are doing that. Telehealth and digital platforms, co-production with families and individuals with lived experiences. Preemptive care is care that can be universal. Good universal antenatal care, good universal care for the mother. That should work. So preemptive is even before anything has happened, you're talking about care for the child. So there is work being done for NDDs where preemptive care for whole populations have been tried. Okay, this is something that we are going to talk in greater depth later today, that this is a big global gap. The biggest global gap is transition to adolescent and adulthood. And all these issues are things that are not adequately touched upon. Mental health, anxiety, depression, and suicidality in adolescent and adult ASD is actually very significant. Even in ADHD children, is very significant. We get caught up with that NDD and we don't spend enough time talking about mental health. So that is something that is to be done. Autistic burnout, school trauma, bullying, loneliness, identity development, all these are things that have to be touched upon. We know about it because of the lived experiences of these people who are grown up and who are now talking about all the things that they went through. Okay. I am a great votary for self-help skills and household skills. How many of you think that all children must do household skills? All children, I'm not talking specially, not about ASD. I think, yeah. And families who have got their children from a young age to do household activities actually are very happy. The children also are very happy about it. And if they have got special needs or NDDs, then household skills are an absolute yes for them. So I'm not going to go into this. I'm just talking about these kind of skills which need to be done. You will find that we spoke about accommodation being there. That accommodation being there makes the young person function very well. What other place can you accommodate than in your own house? And you make chances for the child to help you run the house. That's such an independent skill that he will honor all through his lifetime. Yeah. So I'm in the last part. Parental and sibling needs. All of you who work with families must understand that parents and siblings have needs, and they must, if you're seeing them long term, they must have a way to come and meet you and talk about their needs. Safety net, relatives, respite homes, supervised housing, full-time care are all issues which are burning problems for families. When you talk about scheduling, what is the child's schedule like? There are things that you have to pay attention to. Physical activities are actually loved activities. I don't know whether many of you actually ask parents to keep a logbook. Any clinician who works with chronic ailments will know that having a logbook for the parents works very well because it's a long course that the parents have to go through the lifetime of the child to know what they started, what therapy, what medication, what helped, what didn't help, works very well. So do ask your parents to keep a logbook for their child so that over time you will understand what has helped their child. Okay. I have always found that many families have pediatricians who are actually the first responder for NDD and are actually a continuity anchor. They will go back to the pediatrician if they have had great help from the pediatrician. And even when they are 24, they will go back to the pediatrician to ask because the pediatrician knows their child very well for so many years. So a continuity of care is necessary for children who have NDDs. And as they grow older, the families always like to have one medical professional, one dentist who knows their child very well. So you all must ask them and make it a point to see that that happens for them. Challenges of working in a team, I'm not going to go into it. No single discipline owns autism care. It's not yours to claim. Yeah. And you have to learn how to work in a team. Hierarchy issues are big issues. Ego clashes are big issues. Big issues. So when you know a child is going to many, many people and many, many doctors and many, many carers, you must talk to them. Because I know families who will say, Madam, I'm actually going to occupation therapist also, but I have not told this person because they say no need of going. But their family has found improvement. So there's a great need for people who work together to actually talk about the case. They will help more. Yeah. So what has been the major shift in autism care for the past decade? Autism is no longer viewed primarily as a disorder or a delay. It is understood as a complex neurodevelopmental difference that may involve strengths, definitely can involve disabilities, especially for people who require big support. So there are some who require little support, but a lot of the cases who come to NIMHANS and to places like St. John's and CMC are children who require significant level of support. Disability is big in them. Yeah. I'm not going to neurodiversity. Can wait. I want you to remember that parents always have a riddle. Will it be a question or an affirmation? Can you be what I want you to be? Or I want you to be what you can be. And that takes some discussion. You will have to discuss with the parents. Let's see what the child can do. I know you have wishes for what the child must do. Our medical care is very fragmented. So young people like you who are going to go out and work outside must see that if you're working with NDDs, try to work in a team. Don't be fragmented. Let the speech not be speech and language therapist here, OT is there, pediatrician there. Children have to travel to so many places. Whenever you're set up, try to do work in a team so that the family is not fragmented in the way they go through the day. Many of our families are traveling from one therapy to the other therapy. Okay, I'm done. So this is a complete guide. This Autism Child Mind Institute is an institute whose website is good. Many of you can find a lot of useful information in this Child Mind Institute. The other thing is that there's this website where Jonathan Green is talking about rethinking autism and interventions. That also is a nice point of view of how he thinks that work must be done, how this group must be involved, and how probably we need to change the way we think. I'm sure all of you are aware of this textbook. This textbook is free. You can download it, use the slides in it. It's an online stuff. Use it very much. And this is another book which I have been a co-author, where it can be given to teachers, to primary healthcare persons where there's no psychiatrist. I want to end by saying that a lot of us who see high support needs NDDs sometimes feel nihilistic about what we are doing because the improvements are not enough. So I want to say that according to the theory of aerodynamics, and as may be readily demonstrated by laboratory tests and wind tunnel experiments, that the bumblebee is unable to fly. This is because size, weight, shape of its body in relation to the total wingspan spread makes flying impossible. But the bumblebee, being ignorant of these profound truths, goes ahead and flies anyway and manages to make a little honey every day. So all of us have great reason to believe that what we do can be useful. We just need to be more informed. Thank you. Thank you.
Thank you, ma'am, for sharing your insights into collaborative care and multidisciplinary approach in caring for individuals with autism. The simple analogies you mentioned are extremely relevant to clinicians like us. As a token of our appreciation, we are pleased to present a handcrafted wooden memento thoughtfully created for Autism 360 by our former head of department, Dr. Jacob John. I invite Dr. Jacob John to present the memento to Dr. Shoba Srinath.
Yes. Thank you.
As we celebrate World Environment Day today, this ethically sourced memento adds a very personal touch.